Welcome to Raaonline. I am Dr. Venkatakrishnan, Professor of Medicine. We will have a few questions, MCQs in CVS, the basic questions and some advanced questions we will be discussing. The first question is, giant V waves in JVP is seen in. To understand this concept, tricuspid stenosis, aortic regurgitation, tricuspid regurgitation, aortic stenosis. So, you should know what are the waves in JVP. A wave, C wave which is not seen, V wave, X descent, X dash and Y descent. This is what is the basis of JVP. What is the physiology of waves in JVP? They reflect the right atrial pressure. They reflect the right atrial pressure changes. So, when there is a rise in pressure, there is a rise in JVP, decrease then produces. So, what is A wave due to? A wave is due to atrial systole. A wave is due to atrial. V wave, there is corresponds to ventricular systole, but when there is atrial filling which is corresponding to ventricular systole. C wave, definitely it is a tough question. This is a very easy question. C wave, specifically what is the mechanism of C wave? What is CV wave? But C wave corresponds to isovolumetric contraction. What is isovolumetric contraction? Isovolumetric contraction, the meaning is volume remains same, increase in pressure. That is the first phase of systole. What happens? During that pressure, the cusps, tricuspid cusps move upwards. Tricuspid cusps move upwards. So, mild increase in right atrial pressure which is manifested as C wave. The second concept is because of the direct vibrations, transmissions from the carotid pulsations, you may get C wave, but the exact concept is this: isovolumetric contraction, the cusps move slightly upwards, increasing the right atrial pressure, that causes C wave. Then V wave, what causes V wave? During ventricular systole, there is rise in atrial filling, the atrial relaxation receives more blood from the venous system. If it is receiving more blood, then it causes a prominent V wave. Now, when you get a prominent A wave, the atrium is contracting. When there is a tight valve, tricuspid valve is tight, then you get a prominent A wave. Tricuspid stenosis, again pulmonary stenosis, pulmonary artery hypertension, all will cause prominent A wave. A waves are absent when atrial fibrillation. There is no force of atrial contraction. Atrial fibrillation, no A wave. A wave minus AF. What happens to V wave? When you get a prominent V wave, there is more filling coming from the venous system, but when there is a tricuspid regurgitation, more blood through the leak goes to the RA along with venous return. Tricuspid regurgitation will produce a prominent V wave. So, this is the concept of JVP. This A wave, V wave, C wave, you should know what is the mechanism and where you get. Cannon A waves. What is cannon A wave? Giant A waves. Giant A waves, cannon A waves. Cannon A waves are seen when atrium contracts against a closed tricuspid valve. That happens in, there is no synchrony between the atrium and the ventricle. Atrium contracts against a closed tricuspid valve, that is complete heart block, you get Coronary waves. The answer for this question is tricuspid regurgitation. Tricuspid stenosis will produce prominent A waves. AR and AS will not affect the JVP much. Bell of the stethoscope is used in the following conditions except. For this we should know, bell is for low pitched murmurs and low pitched sounds. What are the low pitched murmurs? All murmurs are high pitched except mid diastolic murmur of mitral stenosis. So, MDM is not the correct answer. In MDM you use bell of the stethoscope. Third heart sound, low pitched. First and second heart sound, normal first and heart sounds are low pitched. EDM is early diastolic murmur which is high pitched. So, you can ask first heart sound, second heart sound can be loud. When it is a loud heart sound, the question is normal first heart sound, second heart sound, third heart sound normal. There can be pathological third heart sound which is high pitched. You get in MR where there is increased flow which produces a S3. Low flow, there is a low pitched S3 which is seen. In early diastolic murmur which is seen in aortic regurgitation, you get a high pitched murmur. So, it has to be heard with the diaphragm of the stethoscope and it is best heard in